Mr. Chairman, ladies and gentlemen, it's my pleasure being here to present data about the newcomer in the treatment of multiple myeloma, the monoclonal antibodies that have been making such a great impact in the treatment of CLL and lymphomas. Monoclonal antibodies have several modes of action when they are going to kill tumor cells. They bind to the surface. They can interact with natural killer cells that will then be instrumental in the killing of the target. They can bind via the Fc receptor macrophages and initiate phagocytosis. They can bind complement factors and activate complement for killing of the target. And they can, in some cases, directly induce apoptosis by binding to the target cell. In my talk, I will focus on two surface molecules on myeloma cells that are of particular interest at this stage of development of immunotherapy of multiple myeloma, the CS1 protein and the CD38 protein. We have one player that is directed against CS1, that is Elotuzumab, that has been in development for some time in phase 1 and 2 trials, and now phase 3 trials are coming to a conclusion. When it comes to the CD38 molecule, we have three monoclonal antibodies that target this particular molecule on the myeloma surface: TarjumaMap, the SAR antibody from Sanofi, and the MorphoSys antibody, which is now developed by Celgene. Among these, TarjumaMap is the one furthest advanced into now phase 3 trials. Coming back to the Elotuzumab, the CS1 molecule is quite specifically expressed by the myeloma cell, so there are very few cross-reactions for this antibody. It has been tested in a single agent with quite disappointing results because only very few patients had any meaningful clinical response. But when it was in the phase 1 trial combined with lenalidomide and dexamethasone, a very interesting signal appeared. So this has been taken out into further testing in phase 2 and 3 trials. So going into the phase 2, after dose escalation in phase 1, the company Bristol Myers Squibb decided to go out with two dose levels, 10 milligrams per kilo of Elotuzumab in combination with lenalidomide and dexamethasone given the usual way, and Elotuzumab at 20 milligrams per kilo. These are given bi-weekly as bi-weekly infusions. The results are shown here. There is a very impressive response rate, and surprisingly the response seems to be better for the lower dose of Elotuzumab compared with the higher dose, both when it comes to response rate and to the duration of response. I think we should be a bit cautious about the interpretation because the numbers of patients studied are small, but can we think that there could be something about the story that less is more? In fact, it has been published recently in Blood that there is a process called phagocytosis where binding of antibodies and interaction with a effector cell with Fc receptor can cause a kind of nibbling of the antigens away from the target cell, so it becomes naked and cannot be killed by the monoclonal antibody. This process is highly dependent on the dose and schedule of the antibody given, so I think we have a lot to learn about how to use monoclonal antibodies in the optimal way. The side effects of treating with Elotuzumab are very mild, mostly related to the lenalidomide and dexamethasone compound of the treatment, with some infusion-related reactions that are very manageable and restricted to the first and second infusion mostly. Coming to the CD38 target, CD38 is a widely expressed transmembrane glycoprotein, so it's expressed on almost all cells of the body, causing a great concern about the possible side effects of this kind of treatment. But luckily, the CD38 expression is very much more pronounced on myeloma cells, and this difference may be the reason why we see a nice response to toxicity ratio with the treatment with this antibody. So the two monoclonal antibodies that are first developed in the clinical setting are TarjumaMap from Genmab and Janssen, and SAR from Sanofi. They have both demonstrated potent in vitro activity, and they are now in phase 1-2, and for TarjumaMap also phase 3 trials. Due to the wide expression of CD38, we had to start off very cautiously with extremely low doses of TarjumaMap when we treated the first patients. So this was designed as a phase 1 trial with escalating from extremely low doses gradually up to 24 milligrams per kilo, and only treating the patients for 8 weeks, and then looking for long-term toxicity to see if the treatment was safe. After having completed this without a major signal in terms of safety, we were able to go into the part 2 and treat for a longer period of time, up to 2 years. The treatment here was with the 8 and 16 milligrams per kilo, since there was no maximal tolerated dose. And the schedule is 8 weekly infusions followed by 8 biweekly infusions, and then monthly infusions for up to 2 years. The results show that in phase 1, the safety study, that TarjumaMap is well tolerated, and we could dose up to the target dose of 24 milligrams per kilo. And surprisingly, we did see a response to the single-agent antibody treatment for the myeloma patients, even if they were heavily pretreated. For the part 2, the expansion study at 8 and 16 milligrams per kilo, we saw also responses, most impressively with the higher dose level of 16 milligrams per kilo, which is now the standard dosing with TarjumaMap in clinical trials. Also, the progression-free survival seems to be better with a higher dose compared to the lower dose. With these nice single-agent results, we were able to go further with a combination and combined TarjumaMap with lenalidomide and dexamethasone. Given lenalidomide and dexamethasone in the usual schedule, and TarjumaMap still with 8 weekly infusions, 8 biweekly infusions, and then monthly infusions up to 2 years. In this combination study, we again had to start with a phase 1 trial showing the safety, starting at 2 milligrams and escalating up to 16 milligrams per kilo of dosing. And then in part 2, when we had no safety signal here, we could go out at in the expansion cohort with 16 milligrams per kilo. You can see in the combination study here, when TarjumaMap is combined with lenalidomide and dexamethasone, that we have very impressive responses with these patients coming down to a very significant reduction of the M component, and also in the dose in the phase 2 part of the study, we see impressive responses. Some of the patients have been treated for a very short time, so they are still responding, and we have not the full effect of the treatment, and expect this to improve with time. The adverse events were mostly related to lenalidomide and dexamethasone, but some infusion-related reactions were seen. The overall response rate was impressive of the combination, 100% in part 1 and 87% in part 2, and still improving, and also deep responses were seen. Accelerated infusion could be done, but with higher incidence of grade 1-2 AEs that are really manageable. Now we are in phase 3 clinical development of TarjumaMap in combination with lenalidomide. The relapse refractory trial has enrolled the patients that were the target and closed for enrollment in March this year. And the new trial coming up in frontline of elderly myeloma patients, treating them in a randomized setting with lenalidomide and dexamethasone plus minus TarjumaMap, is expected to start very soon. A very short mentioning of a combination study where TarjumaMap is taken out in combination with various backbone treatments used in multiple myeloma. TarjumaMap is combined in a phase 1b setting with our Velcade dexamethasone regimen, VMP, VTD, and pomalidomide dexamethasone to look for safety signals and response in this combination setting. The conclusion so far is at this early time point is that the addition of TarjumaMap to these combinations that are well known is well tolerated and did not result in significant additional toxicity. It showed promising response rates, and TarjumaMap did not appear to have a negative impact on stem cell mobilization for those patients going on to stem cell harvest and high-dose therapy. Phase 3 studies are ongoing or will be initiated very soon with TarjumaMap in combination with these combinations. The SAR antibody has been developed in phase 1 and phase 2 trials, also with single agent TarjumaMap showing interesting activity, and it has been taken into combination with lenalidomide and dexamethasone for relapsed refractory myeloma with a dose escalation from 3 to 5 to 10 milligrams per kilo given every second week, and with lenalidomide and dexamethasone in the standard manner. The patients were heavily pretreated, and there was interesting responses observed to this combination treatment, with also a significant duration of the response and nice progression-free survival. Also with SAR antibody, we do see infusion-related reactions that are generally easily managed. There has been no MTD. Finally, I would like to mention a problem that is inherited in the use of monoclonal antibodies for treatment of myeloma, and that is that the antibody will appear as an M component in the serum of the patients that are treated, and therefore it can be difficult to claim CR. We see here the immunofixation M component, heavy and light chain, and we can see the M component here as a spike in the electrophoresis. And when you look at the antibodies, various types, they are all IgG kappa. You can see Elotuzumab appearing as an M component, and this also goes for the other antibodies that are used in oncology. And TarjumaMap also has this property of showing up as an IgG kappa M component, but a new test has been developed that allows us to discriminate between M components of the patient's own and TarjumaMap by adding an anti-idiotypic antibody that will shift the peak of TarjumaMap from this location and to this one, so we can really discriminate and show that this peak is not an M component from the patient, but this is TarjumaMap by adding the anti-idiotypic antibody. So this will allow us to claim CR for these patients. The summary is that we now have a promise of targeted therapy also in multiple myeloma, and we hope that we will experience the same success as we have seen in the lymphoma field. We need to work on this to identify effective combinations, to look at the settings, should it be frontline maintenance, what patients should be the target, all of them high-risk disease, and what about dosing and schedule. Thank you for your attention.